Great. Hello, everybody. My name is Caitlin. I'm going to be moderating this. Welcome to Rover's October session. We're covering gynecologic malignancies. It's my pleasure to introduce our three panelists. We have Dr. Emma Fields from Virginia Commonwealth University. And we additionally have Dr. Markram. He is at University of Alabama in Birmingham. And Dr. Jill Remick, and she is at the Winship Cancer Institute at Emory. We'll be covering endometrial, cervical, and vulvar cases. We've got some poll questions, so it'll be great if we kind of get different interactions and activity. We can see what people say and have some good discussions. You're welcome to put questions to the chat, and if we have extra time after each section, we can address those as well. So we'll start off going forward.
You all for coming to the GYN section of Rover. Fastest in history.
Okay, here we go. So yes, and I'm Caitlin. I'm a PGY4 at University of Alabama at Birmingham as well.
Okay, so we're going to start with endometrial cancer. And this is a subject we were chatting just before getting started that's become quite a bit more complicated, a little bit more challenging in recent years. And we'll discuss some of the reasons why as we go through this case. I'd also like to thank a colleague, Laura Hattout at Rutgers, for sharing some of her slides for this. So this is a 65-year-old, which is a pretty common age group for this type of presentation. She doesn't have any children. She has a medical history of asthma, anxiety, and a melanoma that was resected, presents with irregular heavy bleeding, and she had a transvaginal ultrasound that showed a thickened endometrial stripe. So on her initial workup, the first thing that she had was an endometrial biopsy, which are generally performed in the clinic by the GYN doctors or gynecologist. And that showed a grade 1 endometrioid adenocarcinoma arising in a background of complex atypical hyperplasia. It was P53 wild type. Grade 1, but there was some question about it being a higher grade based on the background. And she had baseline CT, chest, abdomen, and pelvis that just showed the slightly enlarged uterus, but no lymphadenopathy and no metastatic disease. So the first question is, what would you like to do next? So do you want to go ahead and treat her? Do you want to do pelvic radiation with brachy, pelvic radiation alone, brachy alone? Or do you want to do an extensive surgery with a hysterectomy, lymph node evaluation, omentectomy, and washings, or TAH-BSO with a sentinel lymph node evaluation? Okay, good. A nice range of answers. My answer would also be that bottom one. I think the most standard thing to do for ladies that are surgical candidates, and we didn't really talk about that, but surgery has the right of sort of first refusal for these women if they're fit for surgery, because that's really how we not only treat, but stage these ladies. And the standard now really is to do the sentinel lymph node evaluation as opposed to a full dissection. So she has the surgery. It's still a grade 1 endometrioid adenocarcinoma. She has 60% myometrial invasion. There's a comment that she has substantial LVSI, and we'll talk more about that. No involvement of the cervix, tubes, or ovaries. She is POL ultra mutated, so we'll talk about that as well. Node negative and still P53 wild type and proficient MMR status. So the second question is really quite a tricky question at this point, because this is another area of this cancer that's gotten quite tricky and quite complicated with a recent update. I don't think this is something that you would be tested on. But as far as the stage, would you think she's a FIGO 1B because greater than 50% myometrial invasion? Stage 2B because of the extensive LVSI or substantial LVSI, 2B with POL mutation, or 1A POL mutation, or maybe how I feel. I have no idea because it's become too complicated. Okay, wow, really a distribution. The FIGO 2023, you can see at the bottom here, it's a really recent publication, and it's really interesting. Without the mutational status, this patient would be a 2B because of the extensive LVSI. But if you're stage 1 or 2 and are POL mutated, you actually go down to a stage 1A and then have that annotation, because it's such a favorable prognostic feature. So we'll talk a little bit about the data with this. This is data from PORTEC-2, which, if you remember, was a randomization of all women with high intermediate risk endometrial cancer. Of course, this was an older staging, but basically it was stage 1 with either less than 50% invasion but higher grade, or deeper invasion and all grades. And they were randomized between vaginal brachytherapy and external beam radiation. They went back and looked at mutational status in these ladies, and anybody who had this POL mutation had a 10-year cancer-specific survival of 100%. If they had this non-specific molecular profile, it was still very good, 96%. Microsatellite instability, 84%. And then the worst outcomes are those ones that are sort of more like the serous cancers, the P53 mutants, and those are 62%. And then interestingly, if you look at the type of treatment that they got, only the people who got vaginal brachytherapy and had some of these high risk factors were at an increased risk of pelvic recurrence. And the high risk factors, just to make things complicated, were the P53 mutants, this L1 CAM, and then substantial LVSI. So we've got kind of conflicting patterns for the patient that we're talking about today, who's got the POL-E mutation and substantial LVSI. So this substantial LVSI has come up a little bit more in recent publications, and they've gone back and looked at the data from both PORTEC-1 and PORTEC-2, so that involves a very large group of women, and found that with greater than 4 vessels of lymph vascular space invasion, the risk of pelvic recurrence in a lymph node at 5 years is 26%, and significantly decreases with just focal LVSI or no LVSI. So it's a very strong predictor of pelvic nodal recurrence. Some of the other risk factors we talk about are risk factors for vaginal cuff recurrence, but that substantial LVSI is really a pelvic nodal risk factor. So this is a really nice publication by a large group of our GYN RadOnc colleagues with kind of an algorithm of what to do for these stage 1 and stage 2 endometrial cancer patients. So for Our Lady, this is older staging. Sorry, can you go back? But she falls into that stage 1B because she had deep invasion and was grade 1. But she did have invasion and she does have high risk factors. So then it's a question of what to do. And it pushes you a bit towards doing external beam radiation. But of course, this does not account for that POL mutation. So now we can go to the next question. I'd love to know everyone's opinion on this. I'm not sure there is a right answer. But what do you want to do? You know, you're seeing this lady in clinic. You know, she's already gone through this surgery. You've got the pathology results. Do you recommend observation? Because we've seen from this data that these people with POL mutation have a very favorable outcome. Do you recommend vaginal brachytherapy because of the classic high risk or high intermediate risk features? Or recommend pelvic radiation because of that substantial LVSI? Maybe you want to do full court press and combine both, or not sure. Wow. Okay. I know, I'm not sure of the answer either. But I will tell you in this case, I think there's potentially 3 right answers. You know, if you're really a early adopter of the mutational data, I think observation probably is going to be fine. I mean, I think there's a risk of over-treating these ladies. To me, that substantial LVSI does make me quite worried. And I did end up recommending pelvic radiation for her. So you can go to the next slide. I'll show the plan. So pretty standard. You know, I think the nice thing is that for these ladies, using IMRT, doing things like counseling on a full bladder, you're doing 45 gray and 1.8 gray fractions. You know, we can do this really elegantly. It's a mild inconvenience, but we can minimize both acute and long-term toxicity. So I generally sort of have this conversation that if you're the kind of person that is in good shape and you want to do everything that you can to sort of never have to deal with this again, you know, we know we're not going to have a survival benefit, but that risk of having a pelvic lymph node recurrence, I think is still there with the substantial LVSI. And this would really, really bring that down, as we know from prior studies. So I'd be curious to hear what our panelists do. Next slide. But I think the real challenging aspect of this case, as I've discussed, is, you know, how do you decide sort of on this balancing scale of what's more important or what's sort of carries more weight? Is it mutational status or is it the traditional histopathologic risk factors that we've relied on for years and years? And how would you have treated this patient? And then how do you educate, how do you guide patients to determine the optimal treatment decision? I see a lot of underserved patients that kind of say, I'll do whatever you tell me to, doc. So it's really a challenge. You know, I'm thinking of their performance status. I'm thinking on sort of their mindset again, if they're the kind of patient that's going to follow up, if they're going to, you know, just really want to do everything that they can. And then again, balancing the risk of toxicity. If there's somebody that has recovered from surgery very well, maybe it's somebody who can tolerate this without any problem. And then just how comfortable do you feel with sentinel lymph nodes in the cases with substantial LVSI? I think that's challenging. Sometimes you see maybe that they only get one node, and sometimes on the other side of the pelvis, it'll be some fatty tissue or something. And that may be another sort of reason to push to treat. and do pelvic radiation. But in general, I think these are getting more complicated, and hopefully these future studies will guide us a little bit. This is the algorithm for PORTEC-4, where women in this experimental arm are going to be randomized based on whether they're favorable, intermediate, or unfavorable. And the favorable category includes those with this POL mutation, where they will just get observation. MMR deficient will get vaginal brachytherapy, and then the unfavorable patients will get external beam radiation, compared to the standard arm where they'll just get vaginal brachytherapy. And then the rainbow trial is the next slide. And this is very interesting because it's pretty much all comers, all resected endometrial cancer, and purely basing the treatment on these mutational features. And you can see at the bottom here, the POL mutated patients are being completely de-escalated with no further treatment. So hopefully there won't be additional recurrences, but I think we're going to learn a lot more about uterine cancer in the years to come.
Yeah, I'll just chime in here. Of course, Dr. Field has to present a very challenging case, but as she mentioned, these cases are getting more and more complex the more we know about the different molecular subtypes. The one thing I will say is I think like LVSI is kind of, as Dr. Fields discussed, it's conflicting with where it fits in with the molecular status, which we're learning more and more about. All data seems to point toward POL mutants having a very, very good prognosis, but again, we don't know where that fits in with LVSI. And with the extensive LVSI specifically, all that data we know from extensive LVSI being a poor prognostic factor was in the era before we did sentinel node. So that also, as she mentioned, kind of adds another layer of what do we do with this information? I think I would also probably counsel the patient on these kind of gray zones. And kind of if she were seen a year ago, we would, there wouldn't really be much of a question. But now as kind of things evolve, we're learning more. There is a trial that I'll make a plug for because we're trying to open it at our institution. It's NRG-GY032, and it's basically the bottom on this rainbow trial. It's just this bottom, the POL mutant patients. So it took this one arm. It's a phase 2, and so it basically allows patients with early stage, like stage 1 and 2 POL mutant, even if they have high risk features such as extensive LVSI, it allows you to observe them. So you kind of feel a little bit more comfortable because they're on a trial. Hopefully that will give us some more information, but this is definitely a challenging case. And I don't think there is a right answer, unfortunately.
There's probably lots of right answers. It's just very dependent.
We have a couple minutes if someone wants to type into the chat box a question, or if any of our panelists have any further comments or discussion.
What would you do, Dr. Markram? Would you treat?
Well, I was going to try to not contribute to the conversation. I think both of you have been very thorough. I probably don't have anything meaningful to add. I think that I would favor observation for that patient, recognizing that I don't know that that's the right answer, or if it's the best answer. I think it's a right answer, as you said.
Agreed. Yeah.
Okay, great. We'll move on to Dr. Markram.
Hello and welcome to today's episode of The Quad Shot, where we help you down and digest the day's most pertinent cancer news.
This is not a Quad Shot product, but Quad Shot is a partner of ROVER, and we're very supportive of them. Thank you for that introduction. I'm going to do a cervical cancer case. Once again, there's going to be some poll questions that are embedded, and there may be right answers and there may not be. So I do see that there's a question in the chat about endometrial cancer. Do we want to address that now or later?
We could do, go ahead.
I'll type my answer and maybe Jill will too.
Okay, I like it.
Okay, great, thanks.
Okay, so this case is a 37-year-old patient, G3P3, who has a 2-month history of postcoital spotting. And she doesn't receive routine medical care, doesn't really like doctors, to be honest. And she has no contributory family history or past medical history. A physical exam was performed, focusing on pelvic exam with a 6-centimeter mass rising from the cervix. There's bilateral perimetrial extension noted on the bimanual exam. No clear issues with the perineum or no rectal invasion noted. So the question is, how do we work this patient up? This young patient who has bleeding and has a cervical mass. And so, there's a range of laboratory work and imaging studies that are recommended by all guideline bodies. So you're going to get the requisite CBC, you're going to evaluate kidney function, you're going to evaluate liver function, smoking cessation, which is commonly overlooked, is recommended in all patients. Can consider HIV testing, but not mandated. And also, exam under anesthesia with, cystoscopy as indicated is appropriate in your larger tumors or your more advanced tumors. It's not mandated, but something you can definitely consider to help you with staging. And then fertility evaluation or referral is always a recommendation in women of childbearing age. The exam under anesthesia was performed, and the patient had a biopsy that demonstrated squamous cell carcinoma. And they had an MRI scan and a PET scan performed. And there's a 7-centimeter mass with perimetrial extension, no regional or distant evidence of metastatic disease, including visceral organs or adenopathy. So it seems to be a large localized tumor in the cervix area. And so based on this, probably should have asked a different question than this one first, but I didn't. But based on this, the typical guideline recommendation is for non-surgical management. And so as a component of that, I'm going to ask this question: with the patient's external beam treatment, what is the most appropriate systemic therapy for the patient? Is it we're going to do radiation only, radiation is best, or is it adding concurrent cisplatin to the radiation? Is it doing chemoradiation followed by adjuvant or outback carbotaxol? Is it induction chemotherapy followed by chemoradiation? Or is it chemoimmunotherapy with cisplatin and pembrolizumab followed by adjuvant pembro? And so be interested to see what the group thinks. Yes, there is a range of answers. The majority said chemoradiation, but we also have some outback fans, some induction fans, and some chemoimmunotherapy fans. Okay, this is great. So the purpose of this question is to promote some discussion. So nobody put radiation alone, which is wonderful. That has been the right answer for 25 years. So that's amazing. I've always found it funny that you always read the history of chemoradiation and they talk about the NCI put out this alert in 1999. And it's not just that the data supported it, it's that the NCI put out this alert. So if you don't know about that, you should. But yes, everybody got that right. So radiation alone is not the best answer for this patient. Most people picked chemoradiation. And I personally think that is a right answer to this question. There are multiple randomized controlled trials, including meta-analyses, that have demonstrated that there's an overall survival benefit to the addition of concurrent cisplatin-based chemotherapy to external beam radiation. Most people would agree that outback or adjuvant chemotherapy is not appropriate for locally advanced cervical cancer, as evidenced by the outback trial, failing to demonstrate an oncologic benefit. D and E, I think, are kind of interesting and the subject of much debate. So I'll have my hot take, and the panelists may have other thoughts. And at your home institution, people may have different thoughts, but induction chemotherapy is on here because there's a trial called the Interlace trial, which was originally presented about a year ago at ESMO. And it suggested that there was an overall survival benefit to the addition of induction carbotaxol before chemoradiation as compared to chemoradiation alone. And interestingly, that was published just this week. So I haven't had a lot of time to digest it, but I have read it. And, I think that this is an option that is attractive in certain situations. Sometimes it's easier to start chemotherapy than it is radiation. And if you're going to have a delay in care, particularly if you're trying to get care at a, specialized center or center farther away from home, maybe this is a way to expedite starting treatment. I think when you look at the study, I have some questions. About 70% of the patients got point A based radiation, which, although that is considered an acceptable alternative, the overwhelming body of data would suggest that volume-based brachytherapy has better outcomes, both in terms of tumor control and toxicity. And so I think that there's some questions there. The dose was a little low in the majority of patients, and it's a little unclear to me exactly what radiation dose went to the lymph nodes, if there were involved lymph nodes, which almost half of patients had them. So personally, I have a lot of concern about widespread adoption of this technique until we learn more. But I do think it is considered, and some people are implementing this as a standard of care. That's not been my practice or our practice here at UAB. And then the last one is chemoimmunotherapy. So you've got cisplatin plus pembrolizumab, followed by adjuvant pembro. It's about 2 years of pembrolizumab total. And that is the KEYNOTE-A18 study, which was also originally published earlier in this year with a survival update published this month. So some new data for sure. But it did demonstrate a progression-free and an overall survival benefit with the addition of pembro. Interestingly, the FDA label for approval is based on FIGO 2014 stage 3 to 4A tumors. If you all can hear the siren, sorry, I'm by the emergency department. So it's for stage 3 to 4A cervical cancer tumors according to the FIGO 2014 staging system, which basically was large primary tumors. And so, sort of your current 3A, 3B, and 4A. And that is largely based off this forest plot, this subgroup analysis that you can see here, suggesting that the benefit seems to be driven in those 3 and 4A tumors versus your sort of lower 2014 stage tumors. Now, you always have to be really careful about how you interpret subgroup analyses. I'm sure at your institution, people warn you of this. I mean, patients less than 65 also seem to be the ones driving the benefit if you look at the same forest plot. So I think you could also come up with a lot of potential answers here that may be dangerous, but that is what the FDA label is. And we all know that immunotherapy, although well tolerated, is not without its potential for side effects. I think everybody's excited that this is potentially a great breakthrough or one of the best breakthroughs in the last 2 decades. So it is exciting, but some people I know are trying to give it in all stage 3 or all locally advanced patients. Some are giving it in nodal stage 3 patients, which don't perfectly fit into this label or what was studied, but it's definitely something to be aware of. And I think we're in an evolving time both for endometrial cancer and for cervical cancer in terms of what the right answers are. And so it's kind of exciting to be a part of that. So this patient, we gave 45 gray. I think this question's early. Okay. In this patient, we gave 45 gray and 25 fractions using IMRT. And the patient also got concurrent cisplatin, 40 milligrams per meter squared weekly. And then they got image-guided brachytherapy. And this patient was actually treated prior to the keynote data being presented. But, technically as a 2B tumor, she would not have fit that FIGO 2014 criteria according to the FDA for Pembro, but some people are trying to administer it. We have a trial, it's called the RDO cervix trial that we have open, which is an adaptive trial. And this is something that this patient was treated with. And although somewhat unproven in terms of the benefit, we know that the pelvic organs move and change day to day. And there's different ways to address that. And so this is on Variance Ethos, CT-based adaptive LINAC. And this is a 95% color wash. And one of the things that's interesting, as everybody knows, is the bladder can be different every day, the rectum can be different every day, the uterus can move dependent and independent of those organs. And so in order to account for that, we usually have bigger margins. The purpose of this study is to try to have smaller margins and change where that dose goes every day. And so you can kind of see here the left side of the screen. It's a much tighter dose distribution, much smaller than our typical margins that you would see on the right side of the screen. So you've got, in theory, less normal tissue getting radiation and hopefully less toxicity. Just something to be aware of. Obviously, this is on clinical trial and not something that's, widely implemented. We can go to the next one. So after the patient finished their external beam, she received brachytherapy. And a question for the group is, what dosing goal for brachytherapy should you have? Should you make sure that point A receives a total of 80 gray EQD2? Should you make sure that the residual GTV at the time of brachy receives a minimum of 85 gray? That the high-risk CTV D90 goal of 90 gray with 85 being acceptable, or that the V85 gray, do you have a V85 gray goal of 95% of the high-risk CTV? A lot of answers. It's meant to be moderately confusing. But the group was not fooled. So that's great. So, and this is considered the standard for volume-based image-guided brachytherapy, that your D90 is at least 85 gray. There are caveats to this, and we can talk about some of those. The Embrace 2 ongoing trial recommends 90 gray with 85 gray being acceptable, no more than 95 gray. You do have sort of a blurb in NCCN about your dosing goal potentially being lower if you have a smaller tumor, smaller residual tumor at the time of brachy. And so that goal can sort of be reduced to the sort of 80 to 85 gray range. And that's very reasonable. We know from a host of data, Embrace 1 being part of that, where the smaller tumors seem to have really good tumor control even with slightly lower doses. And so I do think that matters and is worth keeping in mind. Embrace did find that there was better tumor control if your residual GTV got more than 95 gray, not 85 gray as mentioned here. And that's an Embrace 2 metric. That's a goal. So this is a good one to file away, the D90 goal. But you all seem to already know that. So good on you. So you can see here, this is 100% isos line for this patient's tumor. You can see down here in the MR that the isos line hugs pretty well what you're seeing in terms of your MR abnormality. The sagittal kind of shows you that you have a tandem, you have a ring, you have some vaginal packing posteriorly, and then you can see in the axial in the upper left that this was a hybrid applicator that we used in order to shape the dose more to the tumor's distribution, which the hybrid applicators are sort of the combined intracavitary and interstitial applicators, as many of you probably already know, allow you to shape your dose to what you need, giving more dose to the tumor or more dose laterally, like in this patient that had bilateral parametrial extension, without simultaneously pushing that dose anteriorly in your bladder or posteriorly in your rectum or sigmoid. So it's a really nice tool to have. There's a lot of different ways to do hybrid applicators or interstitial treatment. This is an example of one of them. We can go to the next one. So in summary, I think that this is a large primary tumor in a young patient. And one of the big questions is, how do we balance tumor control with toxicity? And that is sort of the emphasis of sort of the adaptive trial, or we're trying to reduce some toxicity there for this patient, but also making sure that their tumor receives an adequate dose. We talked about that there's evolving data in terms of systemic therapy and more to come on that. But it is an exciting time to be in cervical cancer care for sure. We also talked a little bit about how these hybrid applicators or interstitial applications can result in better tumor coverage and less normal tissue dose and toxicity, which is also exciting to be able to offer. So with that, I will conclude my section.
Great. If there's any questions or discussion points, our panelists can discuss them, or questions can be in the chat. I think one got answered in the chat already.
Yeah, I think that, as Dr. Markham mentioned, the kind of evolution of cervical cancer is also challenging with the interlace and the A18. I think up front, if you just look at the trials side by side, the A18 trial had much higher quality assurance for the radiation. It was accrued in 2 years, which is extremely fast, meaning that like the radiation was all similar, and the interlace was accrued off a 10-year time span, which, over 10 years, our radiation techniques have evolved significantly. And so that's kind of the one big difference I've seen. And again, I mean, it was just published this week, so I still have to kind of look through the paper, but that's kind of one thing that jumped out at me. And then the other thing is the interlace actually was a much lower risk patient population. Only 16% interlace had positive nodes, where in A18, like over 80% had positive nodes. So it's definitely a different patient population. We were chatting about this issue before we came on, but I definitely think if a patient fits A18, we are absolutely going to be putting that patient on pembro. If they don't, and they're earlier stage and they have a bulky tumor, and for some reason they can't start radiation right away, then I think it's reasonable. But again, with knowing those caveats, and I think making sure the radiation is still high quality is important.
Excellent. Okay, we've got one last presentation section here with vulvar cancer with Dr. Remick.
I somehow drew the short straw with this these talks. So yes, I have the pleasure of presenting vulvar cancer. I'm going to focus more on kind of a board style, just because vulvar cancer is very rare, and if you're go into general practice, or even if you become a GYN radiation oncologist like us all on this call, you don't see them very often, but when you do, you often have to go back and figure out how to treat them again. When I first started, I had a batch of like 3 or 4 patients all at the same time. So I really kind of focused and honed in on, what is the best technique and how to treat these patients, how to monitor these patients through on treatment visits. So that's kind of what I'm going to really focus on. It's going to be more very practical. There's a lot of data, obviously less data because it's rare. But if you have questions, I'm happy to answer them at the end. So this is a 74-year-old female. She has a history of hypertension, a DVT with an IVC filter, and hypothyroid, presents with 2 months of vaginal irritation, worst with urination and yellow discharge. She was referred to a gynecologist and found to have a raised lesion on the right vulva, and it was encroaching into the vagina. And a biopsy revealed P16 positive squamous cell carcinoma with LVSI. And she's referred to you for evaluation. I think there is a question. All right. So this is kind of a trick question. The right answer is 25% based on majority of studies. But I think depending on which retrospective you look at, it can be as high as 80%. The majority of retrospectives that I've looked at, the range is kind of 25 to 30%, which actually was the same in our cohort. We retrospectively looked at our experience here at Emory, and it's about 30%. And then the second question is whether HPV is associated with prognosis in vulvar squamous cell carcinoma. Yes, good. So this is pretty well established now across multiple institutions and multi-institutional studies that HPV actually does have better local control as well as progression-free and overall survival. So that's something that I think needs to be routinely tested for now in patients with vulvar squamous cell carcinoma. You know, I know sometimes it's not and P16 is should suffice. So I always encourage my pathologists know now that I want it. It doesn't necessarily change your management. However, as we'll discuss later on, when you're thinking about doses and when these patients are on treatment, it kind of can help guide you as in your clinical decision making. So I forgot this is not a multiple choice question, but I guess just in general, when you're doing a pelvic exam for patients with vulvar cancer, what types of things are you looking for? First off, you want to see if there's, you're looking at the tumor, you're seeing how big it is, where it's located. If it's involving or going into the vagina, you're also looking at the perianal area and see if it's involving the anus. Pictures are always great to put in your chart because oftentimes you forget and your exam isn't well described. So I always try to enter pictures into the medical record. Also doing rectovaginal exam, make sure there's no fistula, and also trying to do a proper speculum exam, looking at the cervix, the vagina, making sure it's not a tumor that's arising from the cervix or vagina and extending down to the vulva. Otherwise, you're also looking for inguinal nodes. That's the most common area of drainage. And even for early stage tumors, they have about a 20% chance of having inguinal nodes. So you really need to do a complete inguinal nodal exam as well. And then at this point, you do your exam, you have a biopsy, and what would you recommend next? So I typically go straight to a PET scan for these patients, just because it's very sensitive for lymph nodes, and the lymph nodes in the groin tend to be enlarged at baseline. Oftentimes you see kind of slightly enlarged lymph nodes in the groin. So I usually go right to a PET to really identify which nodes are suspicious and if there's any regional or distant disease. So this is the PET for this patient. And as you can see on the left, there's uptake in the vulvar region. And then on the right, you can see there's uptake in the right inguinal node. And again, this is very highly sensitive for involvement. So with this information, we can go to the next slide. So your gynoc sees her and they're concerned about the morbidity of resection. And this is primarily due to the tumor encroaching into the vagina and the extent of the vagina they would have to resect to get a good margin. I am actually finding, at least at my institution, that I do way more definitive than I do post-op, which is why I focused on a definitive case. Just because the surgeries can be very morbid and oftentimes they need radiation afterwards. So what is your recommended treatment approach for this patient? Great. So that was a little bit of a gimme. So cisplatin is the standard. There is, and then the dosing, there's a range of doses for this for vulvar cancer. I think that's where a lot of residents get frustrated. A lot of residents that are studying for their boards, they just want to know, what do you give? And unfortunately, I went back and looked at all my definitive vulvar, and I've done things slightly different each time because you learn and you adapt. And so unfortunately, there's not one right answer. I'm going to show you some examples of, I think, what is clinically appropriate. Another question that might arise is, well, there was a recent trial that looked at adding on gemcitabine to cisplatin, and it was a phase 2, so it was not randomized. So basically all the vulvar studies kind of try to build on the last study. They never have randomized trials because there's not enough patients. And so they wanted to look at, it basically was looking at cisplatin combined with gemcitabine with definitive radiation up to 64 gray. And their primary endpoint was clinical complete response of 70%. And they did meet that, and that's great. They did have very high toxicity as well. And I think the biggest critiques of that trial, and I'd be interested to see what other panelists are doing. We don't routinely add on gemcitabine despite those results. And the major critiques of that trial, which again took, I think, 10 or 12 years to accrue, is that we had been escalating our doses during that time from, 56, 57, 60s, even up to 70 gray. And we've been seeing improved responses without gemcitabine. So it's unclear how much the gemcitabine truly added. And these patients have enough toxicity with cisplatin and radiation. So we are not routinely adding on gemcitabine for these patients. So describe how you would simulate this patient and what would you include in your contours. You can go to the next slide. So I think this is another gray area in terms of how to define your volumes. I think you have to know what you're looking for and what you want to treat. So for this patient, and I have really adapted these based off of the GOG 279 study, the one that was just published with cisplatin and gemcitabine. I always go back to the most recent trial, make sure how I'm contouring is, within, reason compared to the, really the standard of care based on what the experts had written in the trial. So the primary site here, I did the GTV plus a 2 centimeter margin. Now, really important at SIM, I'm sorry, I didn't discuss the SIM, but at SIM, the SIM for these patients is extremely important. You want to be there for the SIM for these patients. They need to be put on their back. They need to be frog-legged. You want to wire out where the clinical target volume is. You don't necessarily need to contour right around the tumor, but at least the area that looks abnormal. I find if you are a gyne radiation oncologist, nobody else is going to want to wire your patients. So, and really, if you're not doing it, it's challenging. If you don't know the patient, you don't know the case. So I usually try to wire out the clinical target volume, the area of interest, and I put as many markers down there as I can. So I'll put a marker at the anus, I'll put a marker in the vagina. Sometimes I'll put a Q-tip in the vagina with contrast at the tip. Just as many things as you can to guide your contouring. And then I do simulate frog leg. I usually try to use IV contrast because these lymph nodes are sometimes hard to identify. And for contouring, I do the GTV plus you need a wide margin for these cases because they can be infiltrating. You can't see them with the naked eye a lot of times, so you have to put a large margin on the primary site. That being said, I don't just expand it and leave it. You kind of want to shape it to where the vulva is. And so that's anatomically modified. And then my CTV margin for the initial is about 5 millimeters, and this total dose is going to 50.4. For the boost portion, so in the next slide, I'll talk about the doses, but for when you're boosting the patient, it's a sequential boost. I tighten my margins significantly. And this is extremely important because they get really bad toxicity. So if you don't modify your margins from your initial, you're going to give them really bad toxicity. So the GTV, I resim them, I rewire them, and I only put on a 7mm margin for the CTV. And then I add a 5mm for the PTV, and I'm doing daily cone beams. And for this volume, I'm trying to get it in that 64 to 70 range. I never go up to 70. I usually get to 64, 66 for these patients. So that's for the primary. And then what about the nodes? For elective nodal coverage, I always cover bilateral inguinal nodes, and I usually always cover the pelvic nodes as well. If they're clinically node negative, I usually stop at the distal common iliac bifurcation. If they have any positive lymph nodes, I usually treat all the way up to the aortic bifurcation, so around L4, L5. And then if they do have any gross nodes, I contour out the node and I give a 5mm margin, and I do daily CBCTs. And you have to make sure that you're able to visualize the groins with your CBCT. If you put your ISO too high in the pelvis, it will cut off your groins and you won't be able to see them on your CBCT. So you have to put the ISO a little bit lower. Next slide. So this is kind of different approaches for these patients. There's not one right way to do this. I've done both and I've gone back and forth. I think that probably the easiest one to remember is doing an SIB initial and then followed by a sequential boost. This is what's done in the GOG 279 trial. And so basically you're doing 1.8s to the you have a 1.8 volume, and the CTVs are defined there in this chart, so you'll have this for reference. And then you can do a 2.3 gray per fraction to the nodes. The thing I worry about here is a 2.3 gray per fraction. If it's a pretty large inguinal node, like greater than 2 centimeters, and it's right next to the vessel, I get a little bit wary of that in terms of fibrosis and risk of lymphedema. So that's just one thing that I have some concerns about. And then again, you have to do that sequential boost to the primary with a tighter margin. So I was doing this approach, and for a couple patients, or my first patient that I did this for, the dose fractionation to the primary side is 2, and I just found the toxicity to be exquisite. And so for whatever reason, I talked to some people, and some be like, oh, we do 1.8s. And so they found a little bit, or actually one of my colleagues here did it. So I then switched over to a sequential approach, and my sequential approach is shown there. And basically just keeping everything at 1.8 and kind of building up from there. And with both of these regimens, you're getting to like an EQD2 of 66. So things that I've learned along the way, so 5mm PTV margin, as long as you're doing daily CBCTs. If you're not able to do daily CBCTs, you might have to, go up to 7. The bolus thing I've always struggled with. I think the bolus can be very toxic, and you often have to remove it within 2 weeks of them starting. So I often, especially for my post-op patients, I always use OSLDs, and I'll measure the dose on the skin for at least the first 3 fractions. And as long as the average of the 3 fractions is over what your prescription dose is, then I don't put on a bolus. If it's below, if there's a gross tumor there, I usually do put on the bolus, but I'm very, very cognizant of, you're doing weekly exams to know when it's time to remove that bolus. You have to approve both plans up front. Okay, so I approve a bolus and non-bolus plan so that when you do take off the bolus, you can easily tell the dosimetrist to swap them out. I resim for the boost, and I wire the GTV or the CTV as long as you know what you're wiring. And then importantly, you want to tighten your margins when you're delivering the boost. Okay, so there's a lot of gray zones, but I think some of the gray zones that came to my head when I was preparing this is really the total dose to the primary tumor and the gross nodes is really unknown. If you look at NCCN, which is shown in this table here, there's wide ranges. And so it's really dependent on the tumor size and the response to treatment, because you have that opportunity to do a sequential boost, so you can adapt to your total dose. And then also now we know the histology, HPVs respond better. And so if I have a patient with this patient had actually a fairly small HPV positive tumor, I'm certainly not trying to get her to 70 gray if when I'm planning her boost, I don't see any tumor. You could probably get away with just doing 64 gray. And this is in line with what we're seeing with other HPV positive squamous cell carcinomas, although we have to be careful with dose de-escalation. But you have to do what's clinically appropriate. If a patient has diffuse grade 3 desquamation, you're definitely not boosting them to 70 gray. The radiation technique, there's benefits and limitations with SIB. Obviously, it's shorter overall treatment time, but you're using a slightly larger dose per fraction to inguinal nodes, which I think might be a little bit questionable for those larger nodes. Sequential allows you to tailor your dose a little bit better, and you're using a lower dose per fraction. So what is the expected complete response rate for all comers? Yeah. So they have really good response rates. Some tumors up front, you're not going to be able to control them, but a lot of them I've had really, really good outcomes. So, it can be very, very rewarding. But that is, I don't think we're going to have time, but I did include slides on management on treatment visits, because that is extremely, extremely challenging. I know we're at time now, so let me know. Yep. So they're listed here. This is kind of what I have come up with, and over kind of some trial and error. And I just encourage you to examine your patients every week, know how you're going to manage dermatitis, know how you're going to manage their pain, whether they need to see wound care, and always, don't forget to take off the bolus. And also consider shrinking your margins more if you need to. And then lastly, sometimes and often these patients do need a treatment break. And I usually monitor them at least weekly, or at most weekly, to see when we can restart their treatment. So happy to take any questions.
There was a question about venous mount. I'm not sure.
Old technique we're used to involve in venous mount.
I think that's just another word for the mons, but I'm still not sure I understand the whole question. So I wasn't sure how to answer it either.
Oh, interstitial brachy. So interstitial, I don't know if you can rephrase that question about the venous mount, and then I'll address the second question. So the second question, oh yeah, well, it looks like Dr. Markram addressed that, but yeah, so interstitial brachy is I do have a colleague that does it. I haven't done it, but there is definitely good data for it, but I think it does have to be done in experienced hands.
Excellent. Yes.
Okay. Oh, okay. So I typically don't cover the whole, I don't cover the whole mons, and it really depends on the size of the tumor, the location. I'd be interested to see what the other panelists do, but I think that adds a lot of toxicity, and I'm not sure I've ever seen a failure there. But again, if it's extending anteriorly, then that area is at risk. So, but no, I don't routinely cover the whole mons.
Excellent. Thank you to all of our panelists. Let's see. Talk about if and how you'd modify volumes if there's urethral or anal involvement.
Yeah, so that's a common scenario. And if it is involving other organs, you just have to extend your margin within those organs. So if it's involving the rectum or the anus, I generally give a little bit more margin along, the along that organ, not circumferentially. So I usually give, I think the GOG study said like 2 centimeters. I usually do like 1 to 2 centimeters depending on the clinical scenario.
Okay, excellent. Thank you so much. And I appreciate, and we can, if you have any questions, feel free to reach out to us at the RadOnc virtual. But otherwise, I hope you all have a good rest of your day.
Thank you for having us.
Thank you.